الطلاب والطالبات المقبلين على اختبار ال SPLE، وأخيراً لتهيئة الطلاب والطالبات المقبلين على كورس العلاجيات في الأورام وأمراض الدم في كليات الصيدلة. وبإذن الله في هذه الدورة حرصنا على اختيار خيرة المتحدثين المتخصصين في هذا المجال، وكذلك حرصنا على اختيار المواضيع المهمة والمتعلقة في المجال التعليمي والعملي. وأخيراً أحب أن أنوه على عدة أمور. أولاً ستكون المحاضرات يومياً بإذن الله ابتداء من الساعة 8 مساء حتى 10، وتتراوح مدة المحاضرات من بين 20 إلى 45 دقيقة بناء على المحاضرة. وفي نهاية كل يوم سيكون هناك مجال للمناقشة والأسئلة. ثانياً يرجى من الجميع الحرص على أن تكون الكاميرا والميكروفون مغلق. ثالثاً يجب على الجميع الحرص على حضور جميع المحاضرات خلال هذا البرنامج في ال5 أيام المقبلة للحصول على الشهادة. وفي الختام شاكرين لكم حرصكم وحضوركم، وبالتوفيق لكم في هذه الدورة. Now I'm pleased to introduce the first speaker in this course, Dr. Mansour Khan. He is a senior clinical pharmacist specialized in hematology oncology in King Abdulaziz Medical City in Jeddah. He will present for us pharmacology of chemotherapy. Dr. Mansour, you can start now, and good luck.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you so much for the introduction, and thanks a lot SOPA for organizing this crash course of oncology therapeutic course. So I should start sharing the screen. I think host disabled the participant screen sharing. Can you allow me to share the screen? Or you will share the screen? Dr. Abdul Rahman?
You will share the screen.
Okay, I was disabled. Actually, I'm not allowed to share until now.
Okay. Now you can?
Yes, I can share it now.
Okay.
Okay. Is it a good view?
Yes, clear.
Okay. Bismillahirrahmanirrahim. We can start it now. You can see this on the screen. Summer crash course in oncology therapy. Can you see this on the screen? Dr. Inas,
Yes,
can you see this on the screen?
Yes,
okay,
yes.
Excellent. Bismillahirrahmanirrahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening to everyone, and we'll begin our first session with oncology, chemotherapy, pharmacology of oncology, chemotherapy, and the target therapy. The first part is by me, which is the pharmacology of the chemotherapeutic agents, and second lecture will be by Dr.Nora. She will talk about target chemotherapy. You know, we are typically teaching chemotherapy, pharmacology to oncology fellow physicians, and in the university, you know, the bulk of knowledge that we learn and that we have to deliver in chemotherapy pharmacology and target therapy pharmacology is really immense, and we need tens and dozens of these kind of lectures actually to complete pharmacology of chemotherapeutic agents. Okay. So these are my objectives. We'll define the important terminologies related to intent and types of chemotherapy and cell cycle concepts. We'll try to talk about the body surface area concept for dosing antineoplastic agents. This is different kind of concept actually when we apply the dosing concept for the antineoplastic agents. We'll try to illustrate some of the mechanism of actions of major classes of chemotherapy, and Dr. Nora will talk about the targeted agents. We'll describe the indications of antineoplastic agents, and we'll try to address some of the most common side effects and unique toxicities of the antineoplastic agent. Of course, it's not possible to cover the entire scope of the chemotherapy pharmacology in 45 minutes. We'll try to finish it as soon as we have been assigned to finish in 45 minutes. So let's try to understand what is the cancer, what is the word cancer means, which is sartan. So this is, you know, in our body, cells are multiplying all the time. For example, bone marrow cells, mucosal cell line cells, or rapidly dividing cells. But sometimes what happens due to mutation or due to whatever mechanism, cell starts to divide in an abnormal fashion. And that can result into tumor, which could be malignant tumor, which could be benign tumor. If it is malignant tumor, it's called cancer. The cancer cells actually, they can spread to the other parts of the body through the blood, the vessels, or the lymphatic system, and that process is called metastasis in solid tumors, and this process is called infiltration in case of leukemias. We have to also understand some other important definitions. Because the chemotherapy is cytotoxic. It's not only cytotoxic to cancer cells, but it's also cytotoxic to healthy cells. So therefore, we have to give ample amount of time for the healthy cells to regenerate. And at the same time, we should not give rest to the cancer cells. So we have to give chemotherapy at the regular interval, at appropriate interval, typically every 3 weeks, or some chemotherapies are given every 2 weeks. Some other chemotherapies are given every 4 weeks. Chemotherapy, as I mentioned, it is cytotoxic, so it is associated with significant side effects. Before 1990, some patients having curable diseases, they were actually refusing to take chemotherapy because of chemotherapy-induced nausea and vomiting. One of my colleagues will talk about chemotherapy-induced nausea and vomiting as a separate lecture. So after the development of the novel antiemetics, people were able to tolerate the side effects of chemotherapy. Some chemotherapies can cause bone marrow suppression, neutropenia, infections, mucositis. So what we try to do, we give the antidotes. For example, with methotrexate, we combine leucovorin, we give antiemetics, we give hydration to prevent the nephrotoxicity, for example, in case of methotrexate. So the combination of the chemotherapy medications along with these supportive care medication is actually called supportive therapy. So we have to support the patient with the supportive care therapy in order to minimize the side effects of the chemotherapy. You might have heard about chemotherapy protocol in the university. So chemotherapy protocol is basically, it's a regimen which may contain one or more than one chemotherapeutic agents, or chemotherapy plus targeted therapy, therapeutic agents, and plus it also contains the supportive care therapy. So it's a complete set of treatment regimen which is designed to treat a certain malignancy. And of course, this chemotherapy protocol is evidence-based, either it has been tested in phase 2 clinical trial or phase 3 clinical trials. This is an example of a chemotherapy protocol in which 2 chemotherapeutic agents are combined in this protocol, doxorubicin, which is also called adriamycin, and cyclophosphamide. Doxorubicin is an anthracycline and cyclophosphamide is an alkylating agent. So this protocol is called AC protocol, A for adriamycin, C for cyclophosphamide. The dose of doxorubicin 60 milligram per meter square is given IV push over 15 to 30 minutes, and cyclophosphamide is 600 milligram per meter square. This is what I was talking to you, and I will talk to you in a couple of minutes. What is the body surface area concept? So we have to calculate the body surface area in order to, for example, if the body surface area of the patient is 2, then the doxorubicin dose, the final dose will be 120 milligrams. 60 times 2 will be 120 milligram total dose. And the chemotherapy protocol tells you the administration guidelines. It also tells you about the supportive care therapies. It also tells you, for example, the patient has hematological toxicities, neutropenia, so how much dose we should reduce. So all these sets of information is actually called chemotherapy protocol. We have more than 500 chemotherapy protocol in our area software library, which we are using for different solid tumors and hematological malignancies. So for the diagnosis of the cancer, typically a patient presents with certain specific signs and symptoms. For example, a patient having leukemia will present with signs of infection, signs of due to neutropenia, and patient may present with fatigue, and that can be typically due to anemia. And some patients may have bruises and ecchymosis, and that could be due to thrombocytopenia due to leukemia. So when the patient presents with these kind of symptoms, so the physician will do the complete blood count, and that tells you that this complete blood count is not normal, and then that will followed by the tissue diagnosis, so bone marrow biopsy. If it's a solid tumor, again the tissue diagnosis. If there's lymph node disease, again the tissue diagnosis. So tissue diagnosis, which is biopsy, is essential to start the treatment. We have a quiz actually, which will be followed in a couple of minutes. So the tissue diagnosis is essential to start the treatment. Why? Because sometimes the tissue diagnosis, which is done in an outside hospital, when you do it in your hospital, it may change. So it happened many times, more than 10 times I've witnessed it actually, the tissue diagnosis has been changed. So we should not start the treatment until the tissue diagnosis is established. There are different tumor markers. You can see the breast cancer, CA125, CEA, which can be also elevated in case of stomach cancer, in case of colon cancer. There are a variety of different tumor markers. However, these are not specific to one particular malignancy. So you cannot start the treatment based on the tumor marker and based on the presenting signs and symptoms. You have to have the tissue diagnosis in order to start the treatment. And once you have the tissue diagnosis, then you have to stage the disease. For example, if it's a solid tumor, then we use TNM classification. Just I will try to use in a simple way. The T stands for the size of the tumor, which I'm not going to go into the complexities of the size of the tumor. So that typically tells you how much is the size of the tumor and the number of the lymph nodes involved. This is the nodal involvement. And M stands for the metastasis. So, for example, if the disease has spread to the other parts of the body, that means that the disease has metastasized. So typically, for example, if we talk about the breast cancer, so stage 1 and 2 is early breast cancer, and stage 3 will be local regional spread of the disease, and stage 4 is the disease where the disease has spread to the other parts of the body. So typically, in stage 1 and 2 and up to 3, our aim is to cure the patient from the malignancy. And in stage 4 disease, in solid tumors, most of the solid tumors, our aim is to reduce the symptoms of the disease, and we use palliative intent chemotherapy unless we have hematological malignancies, such as lymphoma. Even in stage 4 disease, the intent of chemotherapy is curative. So this is what I was referring to. So leukemias, lymphomas, testicular cancer, germ cell tumors, nasopharyngeal carcinomas, these are the tumors where we are trying to use curative intent. And also the early stage breast cancer, or even the stage 3 breast cancer, colon cancers, early stage colon cancer, stage 1, 2, and 3. So these are the examples actually where we are trying to use curative intent chemotherapy. Our aim is to achieve cure. Whether we achieve this with chemotherapy or with surgery or with combination of chemotherapy and surgery or combination of chemotherapy and surgery and the radiation, our aim is cure. And as I mentioned, in stage 4 disease or in advanced disease, our aim is palliative, or in those leukemia patients who are not responding to the frontline therapies and they're not candidate for other intensive treatment options such as bone marrow transplant. So the intent of the chemotherapy in those patients will be only palliative. We have to understand some other terminologies, what is neoadjuvant therapy and adjuvant therapy. So let's take an example of the breast cancer. If the patient has stage 1 and 2 disease or on stage 3 disease, and stage 3 disease, the size of the tumor is bigger, and we would like to reduce the size of the tumor to make it surgically resectable. And after giving like 4 to 6 cycles of chemotherapy, which is called neoadjuvant therapy, we can reduce the size of the tumor, and the surgeons can easily manipulate and do the surgery. And actually in HER2 positive breast cancer and triple negative breast cancer, what we have noticed, around 50 to 60% of the patients, when they receive neoadjuvant therapy, they will be free from the tumor at the time when they are taken to the OR for the surgery. So that's called pathological complete response. And also some female patients, they would like to have the breast conservation surgery. They would like to have the minimally invasive surgery. And for that reason, we use the neoadjuvant therapy in order to reduce the size of the tumor, to make it, in order to minimize the area of the surgery, and that really helps in the breast conservation surgery and the reconstruction of the breast. And adjuvant therapy is actually defined as therapy which is followed by the mainstay of the treatment. For example, in breast cancer, the curative treatment option is surgery. So surgery will remove the tumor, and after the surgery, we would like to give certain type of therapy, chemotherapy, or also target therapy can be used as adjuvant therapy in order to minimize the micrometastatic disease coming back. So in order to prevent the relapse, actually, or the recurrence, we use the adjuvant therapy. There are some other terminologies, particularly in hematological malignancies. For example, induction therapy is actually used in acute leukemia in order to induce remission, in acute lymphocytic leukemia and acute myeloid leukemia. And consolidation therapy, which means to consolidate the remission. For example, the patient is in a state which is free from the leukemia. We would like to consolidate this remission state. Consolidation means, I think, madboot in Arabic. Would like to make this consolidation stronger. I mean, we would like to make this remission state stronger and lasting longer. For that reason, we have to give intensive chemotherapy after the patient has achieved complete remission. And in some kind of acute leukemia, such as acute lymphocytic leukemia and some subtypes of the acute myeloid leukemia, such as acute myelocytic leukemia, we provide a maintenance chemotherapy over the period of 2 to 3 years in smaller doses in order to prevent the cancer coming back or leukemia coming back. So now we move to the first question. You can scan this code in order to answer the question, and that is the question: which one of the following diagnostic method is essential to start chemotherapy? Option A, sign and symptom. Option B, tissue diagnosis. Option C, tumor markers. And option D is strong family history. Dr. Ines, if you can coordinate, we can
Yes,
wait.
okay.
I guess
I will share my screen, and they will see the question. Okay.
Sure.
Can you see the question? So please answer the question by enter menti.com.
Excellent. I think we have received so far 16 responses only out of 100. It's too little number of responses. 23, yalla, speed up. Speed up, we need at least 33%. Come on. So I think we can close the poll because it has been more than a minute. Can we close the poll? Okay, the question number 2 is, what is the main goal of the treatment in early stage breast cancer? Very good, we have 21 responses. Excellent. Received 40 responses, 44, very good. Yeah, that means Most of the people are actively participating. That's good. 54 responses. Excellent. Four responses. Excellent. And we close the poll now.
Okay. Can you share your screen now?
Sure. Yeah, excellent. Thank you so much. I think most of you have replied question number 1, tissue diagnosis, and that's correct. You cannot start the treatment based on silent symptoms and tumor markers, a strong family history. So the tissue diagnosis is essential to start the treatment. That was the correct answer. And the question number 2, the D is the correct option because in early stage breast cancer, our intent is curative. So I think more than 80% people have chosen this answer, which is the right answer, curative intent. Thank you so much for your attention. Now let's try to understand the body surface area concept. So most of the chemotherapeutic agents that we are using, actually we have to dose them either based on the body surface area or per kilogram. So most common body surface area formula which is used in clinical practice everywhere is the Mosteller's formula. Mosteller's formula is equal to weight in kilogram in height in centimeters. And you divide it with 3600 and you take the whole under root. So if you have the weight and height of the patient, then you have to divide it with 3600, then in your calculators take the whole under root. And after you take the under root, which is called Chizab, you take the two digits after the decimal point. For example, if it is 1.734, so you will only take 1.73. Okay, and no need to round it up, round it down. Okay, just take first 2 digits after the decimal without doing any rounding. Average BSA is around 1.73, but in our population, we have mainly obese patient population, and most of the patients that I've seen in leukemia, in like hematological malignancies, their BSA is around 2. And in solid tumors, some malignancies, their BSA might be low because of patients are cachectic or underweight. So now you're going to use this formula, and I have a question here. And again, Dr. Ines will share her screen with you to see the question. Dr. Ines?
Yes, this is the question.
Yeah, I think we are running out of time, so we need to do it a little bit quickly. Even if we have the 10 responses, that's fine. I think it needs a lot of calculation, so perhaps it's a little bit difficult maybe. We didn't receive any response so far. Whether right or wrong, there is no response yet, so that needs mathematics, actually, calculation. I think nobody would like to answer because it's really too difficult. Okay, we went. I think we went to this question. It's actually was not required at this point. We need to go there first, actually. If I can share my screen now.
Okay.
So basically 1.76 meter is the right answer. Now we have to understand the cell cycle concept and the site of the mechanism of action. So this is a human cell, or healthy cell, and the cancer cell also follows the same pattern when it, for the cell replication. So G1 phase is basically preparatory phase for the S phase, where the DNA synthesis takes place. During the G1 phase, the protein and enzyme which are required for the DNA synthesis actually takes place. In the S phase, actually the DNA synthesis takes place. In G2 phase, there's a preparatory course for the mitosis to take place, and these enzymes and proteins which are helpful in the mitosis, actually that takes place in the G2 phase. And in M phase, actually the actual mitosis takes place, where the parent cell is divided into two progeny cells. So you can see there are different drugs acting on different cell cycle phases, like steroids and asparaginase in G1. A lot of antimetabolites are working on S phase. We have etoposide working on G2 phase. We have many vinca alkaloids and taxanes working on mitosis phase, M phase, and the G0 is the resting phase. So many medications or chemotherapeutic agents are cell cycle specific agents. That means that they are exerting their effect on a specific part of the cell cycle. And that's why we try to arrange in a chemotherapy. I mean, we try to use different chemotherapeutic agents in a chemotherapy protocol from the different mechanisms of action, so they can target different parts of the cell cycle in order to have pharmacodynamic synergy, but minimize in order to have lesser toxicities. Some chemotherapies are not cell cycle specific agents, for example, alkylating agents, and targeted therapies. Dr. Nora will talk about that, and they exert their effects on specific tumor. So these are the classes that we're going to go over. We have first class alkylating agents. There are subclasses: nitrogen mustard. We have micloritamine. We are not using micloritamine anymore. Cyclophosphamide, ifosfamide, melphalan, bendamustine, cisplatin, carboplatin, oxaliplatin. We have all these alkylating agents under the nitrogen mustard available in our formulary, except the micloritamine. From the nitrosoureas, carmustine, lomustine, streptozocin, dacarbazine, procarbazine, temozolomide, we are using all of these medications except the streptozocin. We'll talk about them one by one in details. And then we have ethylene imines, which is tiotepa, and we have alkyl sulfonate, busulfan. We are using all these alkylating agents in our hospital. And anybody, actually, a big oncology center, they must be using all these alkylating agents in their hospital. We not except micloritamine and streptozocin. Then we have antimetabolites, antimicrotubule agents. We have two different types of the antimicrotubule agents. We have vinca alkaloids and taxanes. So vinca alkaloids are vinblastine, vincristine, and vinorelbine, and taxanes are docetaxel, paclitaxel, and cabazitaxel. Eribulin is pretty similar to the taxane, but it's not classified under the taxanes. Then third class is topoisomerase inhibitors. We have topoisomerase 1 inhibitor, which cut one side of the double helix, and the topoisomerase 2 inhibitor, which cut the two sides of the double helix. We'll talk about them in details. And then we have antimetabolites. It's another big group of chemotherapeutic agents. We have methotrexate, pemetrexate under the folate antagonist. We have purine analogs, cladribine, fludarabine, mercaptopurine, and thioguanine. And under the pyrimidine analogs, we have capecitabine, cytarabine, 5-fluorouracil, and gemcitabine. We have all these medications available in our formulary to manage different malignancies. And then we have some hormonal agents, bicalutamide, glutamide, and we have LH-RH analogs, luprolide, vazelin, digarlix. I don't want to talk about CDK4/6 inhibitor, as some people will talk about that. We have anti-estrogen, tamoxifen, magistrol, acetate, and we have abiraterone and enzalutamide. I guess Dr. Nora will talk about them. We have aromatase inhibitors, letrozole and estrozole and exemestane. And there are some miscellaneous agents, yes, asparaginase, or arsenic trioxide, which is zernic, and some poison, but we use it in small doses for APL. All transgenic acids, dactylomycin, bleomycin. We have all these agents available in our formulary to treat different kinds of malignancies. So now let's begin with the pharmacology of the alkylating agents. So alkylating agent, they typically make an active moiety of ethylene ammonium compounds, which bind with the N7 atom of the guanosine, and that is responsible for 90% of the alkylation in the DNA. I think Dr. Ines and the SOFA administrator will share with you my slides and everybody's slides, so you can go through the details. Because of the paucity of time, I'll try to go over the slides quickly. So because of this alkylation, the cytotoxic effect can happen by inhibition of the DNA replication and transcription. There could be mispairing of the DNA, and that results in the strand breakage as well. So what is the dose-limiting toxicity? Dose-limiting toxicity typically is a toxicity which happens in 2 out of 3 patients, like grade 4 toxicity, or 2 out of 6 patients, grade 4 toxicity. Grade 4 toxicity is a severe toxicity, and in dose-finding studies in the clinical trial in smaller cohorts of 3 patients and 3+3 design patients. So they try to increase the dose and see the toxicity. And if this toxicity happened 2 out of 6 or 2 out of 3 patients, then that is called dose-limiting toxicity. And what the clinical trialists do, that they try to go 1 step down, and that is called the maximum tolerated dose. And each drug or a group is known for its dose-limiting toxicity. For alkylating agents, the dose-limiting toxicity is bone marrow suppression, particularly neutropenia. And for carboplatin, for example, it's particularly thrombocytopenia. Other toxicities, the nausea and vomiting, alopecia, common toxicities of the alkylating agent, but that happens after a longer period of time. So those patients who had received alkylating agents, you may see secondary leukemia like AML after 10, 15 years, and that typically you see in the survivors of the adult childhood leukemias. In contrast to the anthracycline, topoisomerase 2 induced secondary leukemia that may happen typically in shorter course of time, like within a year, within 2 years. Okay, so that is the metabolism of the cyclophosphamide, which is one of the prototype of the alkylating agents. So basically, you need an active liver in order to metabolize cyclophosphamide through the P450 cytochrome enzyme system into 4-hydroxycyclophosphamide. That is converted to aldophosphamide, and aldophosphamide is converted to acrolein and phosphoramide mustard. Acrolein is responsible for one of the key common toxicity of the alkylating agent of the cyclophosphamide and ifosfamide, and that is hemorrhagic cystitis. It binds with the wall of the bladder and produces hemorrhagic cystitis. So what we do basically, we give an antidote. It's called mercaptolate sulfonate sodium, or it's called Masna. So we always combine Masna with ifosfamide and higher doses of the cyclophosphamide in order to prevent hemorrhagic cystitis, and that is one of the question MCQ coming, question number 4. And phosphoramide mustard, and that is the key component, an active metabolite, which actually alkylate the N7 atom of the guanosine, and responsible for the cytotoxicity from the cyclophosphamide. So the key message, take-home message, the acrolein is one of the toxic metabolites which can cause hemorrhagic cystitis, and we have to give Masna in order to prevent hemorrhagic cystitis. So supportive care part, whenever we use the ifosfamide, will be to combine it with the Masna, or with the higher dose of the cyclophosphamide, we have to use Masna along with it. Okay, so there are some unique side effects and clinical uses of different cyclophosphamide is used for a variety of indications, and ifosfamide also used for a variety of indications. There's a common side effect, hemorrhagic cystitis between cyclophosphamide and ifosfamide. For that reason, we have to give them Masna, and we have to counsel the patient to take enough amount of fluids. If they're drinking orally and they need to void immediately, they go to the washroom and void immediately, because if the urine is staying in the bladder and that is having more and more acrolein, that causes the hemorrhagic cystitis. Okay. There are some other side effects, bone marrow suppression, which is common for all of them, and we're not going to talk about that. And sciatica is also common with the cyclophosphamide, particularly when it's taken with the vincristine. Melphalan can cause myelosuppression, nausea, vomiting, and of course, all these alkylating agents can cause bone marrow suppression, as we mentioned that the dose-limiting toxicity is the bone marrow suppression. Cisplatin is nephrotoxic as well as neurotoxic, so we have to give ample amount of fluids before and after the cisplatin, and we have to give magnesium and potassium before and after the cisplatin, because it can cause significant hypomagnesemia and hypokalemia. And for carboplatin, we have to use a specific formula that's called Calvert formula, and where you use the target AUC, which is the area under the curve, you assume the bioavailability of the carboplatin by using the different AUC factor, which is from 4 to 7.5, typically up to 8 as well. So patients those are going for curative intent, for example, ovarian cancer, you can start them with 7.5 AUC. And most of the people actually use the AUC of 6 for ovarian cancer. And if you're using palliative chemotherapy, you can use the AUC of 4. For a salvage kind of regimen like ICE or RICE protocol, you use the AUC of 5. So you basically take the AUC, whatever the oncologist decides, and you calculate the creatinine clearance by the Coker-Galt equation and add 25 to it and multiply with this. And the maximum creatinine that we can use is 125 ml per minute. If it is more than that, you just round it to 125 ml per minute. Okay, so the side effects of the cisplatin we mentioned, like cisplatin is very well known to be immunogenic, is a highly immunogenic chemotherapeutic agent, and it's a prototype of the drug. When we talk about immunogenicity, the first drug that comes in our mind is the cisplatin. It can cause terrible nausea and vomiting, and that's why you have to use 3-drug or 4-drug combination based on the new ASCO and NCCN guidelines in order to prevent the nausea and vomiting associated with this. Cisplatin is nephrotoxic and myelosuppressive and autotoxic as well. It can cause peripheral neuropathy. Carboplatin as myelosuppression is typically thrombocytopenia, but its incidence of nephrotoxicity is lesser. Incidence of the nephrotoxicity with the carboplatin is even more lesser. And nausea and vomiting of the carboplatin is actually, according to the new guidelines, carboplatin, when you're using the AUC of 5 or more than 5, it is highly immunogenic. For oxaliplatin, is the most common side effect is actually laryngeal spasm, laryngopharyngeal spasm, especially when they are exposed to cold. So there's 2 different kinds of neurotoxicity: early onset, which is mainly due to cold-induced laryngeal spasm, and the chronic, which develops over time after the exposure of the oxaliplatin for about 6 to 12 cycles. There are some other alkylating agents: carbamazine, dacarbazine, procarbazine, temozolomide, busulfan. Actually, I'm not going to go into the details, as you can have the slides, and you can go over them, the clinical uses and the common side effects. Mechanism of action of all of them are the same. Now we have MCQ number 4, and Dr. Ines can share the slide for the answer, please. Dr. Ines. I think that's correct. We have 15 people responded because of paucity of time, so we need to close the polls quickly. 17, 19, 20. I think that's fine. Enough, I think. Enough. I think that's correct. Hemorrhagic cystitis. Whenever you use ifosfamide, you have to always add mesna in order to prevent hemorrhagic cystitis. Correct. I'm happy that most of the people are answering the questions correctly. Okay. Okay, now we move to the topoisomerase 2 inhibitors. Topoisomerase 2 inhibitors, these are basically the medication which cut the double helix, double strand breakage. Actually, cut the double helix from the 2 sides and produces the double strand breakage. So we have under the topoisomerase 2 inhibitors 2 different classes. One of them is the anthracycline, another one is the etoposide. Anthracycline, which are daunorubicin, doxorubicin, idarubicin, and apirubicin, their mechanism of action, the key mechanism of action is the topoisomerase 2 inhibition, which cuts the double helix from the two sides and produces the double strand breakage, and also it produces free radicals like superoxide, which is cytotoxic, and actually our body can dispose of superoxide by a mechanism called superoxide dismutase. So Allah subhanahu wa ta'ala has created superoxide dismutase in our body to dispose of this superoxide and prevent us from the cytotoxicity of the superoxide. But unfortunately, superoxide dismutase is not present in ample amount in heart, and that's why the anthracycline can cause significant cardiotoxicity and can cause heart failure. The daunorubicin, doxorubicin, idarubicin, and apirubicin, these are anthracyclines, and they can cause cardiotoxicity. So these are used for a variety of indications and different doses, and if the drug is leaked out of the blood vessels, then it can cause extravasation, so you have to have the extravasation ready, and that's really an emergency. And this antidote, DMSO or doxazoxin, has to be used if it's available. And as anthracyclines are really cardiotoxic, and there's a lifetime accumulative dose of the anthracycline, doxorubicin should not be exceeded more than 450 to 550 milligrams per meter square. And all other anthracycline, you can convert them to doxorubicin, and that's what we do in the clinical practice. And we should not be using doxorubicin more than 450. Actually, in pediatrics, their cutoff is even lesser, like 300, 375 milligrams per meter square, because these patients, they tend to live longer, and the survivors of the pediatric leukemia patient or pediatric malignancies patient, their risk of having cardiotoxicity is increased when they live longer. But for that reason, the cumulative dose that can receive in the lifetime is lesser than the adults. One other thing that the anthracycline can cause the red discoloration of the urine, so we need to talk to the patient and educate them about it. Etoposide is also topoisomerase 2 inhibitor. It has a variety of indication, and it also can cause myelosuppression. Nausea, vomiting is also one of the side effects of the etoposide. Irinotecan is the topoisomerase 1 inhibitor. It cuts only one side of the double helix and produces single strand breakage, typically used for colorectal rectal cancer, and also used for the lung cancer, and can cause diarrhea. There's two types of diarrhea that it can cause. It can cause acute diarrhea that's typically cholinergic in nature, and you have to use atropine as an anticholinergic for prevention and treatment of diarrhea if it happens within 24 hours. If it is a late diarrhea that's due to mucositis, then we can use loperamide for that. Then we have the zinc alkaloids, and we have vincristine, vinblastine, and anoralbine. What happens actually in the metaphase, the microtubular polymerization takes place. So vincristine, vinblastine, and zinc alkaloid, what they do, they try to inhibit the polymerization of the microtubules, and hence what happens, the cell cycle errors take place in the mitosis phase. These drugs are excreted, metabolized, and excreted through the liver. So in case of hepatic insufficiency, the doses of the drug have to be adjusted. Vincristine is not myelosuppressive, but the vinblastine and vinorelbine are myelosuppressive. Vincristine is much more neurotoxic agent, and if it is given recommend not to give the vincristine in the small syringe. Actually, you have to prepare the dose in the piggyback so that it's not confused with the intrathecal chemotherapy. And neurological toxicity is quite common, and also it can cause constipation. Taxanes are pretty similar mechanism of action to zinc alkaloid, but what they do, instead of inhibiting the polymerization, what they do, they make stabilization of the polymerization. And the same thing happens, the cell cycle arrest takes place because these progeny chromatid go back to the different poles, and then the anaphase, the spindle fiber formation, which is formed, it is not, so again, it's working the mitosis phase. So both paclitaxel, docetaxel, they are can cause severe myelosuppression, and all of them they are neurotoxic and can cause peripheral neuropathy. Then we have the antimetabolites, and methotrexate and pamitrexate. Because of the paucity of time, we cannot go over all these antimetabolites, and I have kept only the example of the methotrexate here. So for methotrexate, it is dihydrofolate reductase inhibitor, and it the conversion of folic acid, which is dihydrofolic acid, that is present in our food, and it prevents the conversion of the dihydrofolic acid to tetrahydrofolic acid, which is the active form of the folinic acid. And for that reason, we have to provide patients with a leucovorin of folinic acid, which is antidote of the methotrexate, 24 hours after the exposure of the methotrexate. And it can cause leukopenia, thrombocytopenia, it can cause renal failure. So we have to alkalinize the patient. Alopecia, and typically we use high-dose methotrexate in hematological malignancies and CNS lymphoma, which is defined as any dose above 0.5 gram, and we can use up to 12 gram in osteosarcoma. And of course, we have to provide hydration, below 0.05. Those patients who have third spacing fluids such as ascites, blood effusion, these are the contraindication for the high-dose methotrexate, because high-dose methotrexate can stay in this third space and it leaks back into the circulation and its excretion is delayed, and that results in significant toxicities. So this is the managing principles of the high-dose methotrexate. You have to maintain very good urine output with hydration plus minus furosemide. You have to do the urinary alkalinization, keep the urine pH above 7.5 by using the sodium bicarbonate in combination with IV fluids such as dextrose 5%. We monitor the serum creatinine on daily basis and electrolytes. We also give them potassium because the sodium bicarbonate can shift the potassium to the intracellular compartment. We keep monitoring the methotrexate level until the methotrexate level is less than 0.05 or at least less than 0.1. And some patients who may have very high levels of the methotrexate level, and they have like kidney function deteriorating, so they may be candidate for the glucarpidase, which can oxidize or detoxify like 97.5% of the methotrexate within 15 minutes. But this drug is not cost effective. One dose is costing around 250 to 500,000 reals per dose. So we have done a study in 500 doses, and we have found only 2 patients actually required hemodialysis, and that was reversible. You have to avoid some medication with the high-dose methotrexate because they can increase they can delay the excretion of the methotrexate, the penicillin, omeprazole, salicylate, sulfonamide, and that's the last question that we have on our screen. Which one of the following medication is known to cause cardiotoxicity in the cancer patient? Remember which medication I was focusing on. That can, Dr. Ines, if you can share the screen. Remember, like I mentioned that there is a group of medication which can produce superoxide, and superoxide. Dr. Ines, please share the screen to answer this. So you remember, like I was mentioning, there's a class of compound which can produce superoxide, and these superoxide. No, the next question. Next.
Yeah,
question number 5.
The last one, right?
The last.
Yeah.
So that can cause cardiotoxicity because superoxide dismutase are not present in the heart in ample amount. No, next question. Next.
Okay.
Yeah, this question. Yes, that's good. Good. We're running out of time, so I think we can close the poll in order to be with the time. I think 1 minute overdue. So I think that's correct, Dr. Ines. We can close the poll. So most of the people have voted for doxorubicin, which is anthracycline, and that can cause cardiotoxicity. And with that, I would like to say thanks for your attention. Thank you so much. Thanks, Dr. Ines. I'm done.
Thank you, Dr. Mansour. Any question for Dr. Mansour?
I think it's at the end of the session. Oh, it's fine. I can answer the question now. That's good.
Okay. Okay, خلاص. In the end of the session. Dr. Mansour, you are mute. Can you unmute yourself? And they
Yeah, I mean,
so they can ask you.
if somebody can ask you a question, it will be done because I'm busy today, moving my, shifting my accommodation. So if somebody can ask me a question, I'll be done. That's very good for me.
Please write your question for Dr. Mansour. You can unmute yourself and you can ask Dr. Mansour if you want.
I think there is one question. There is one question. What is anti-tumor antibiotics? So anti-tumor antibiotics like doxorubicin, anthracycline is one of the anti-tumor antibiotic. Bleomycin is one of the anti-tumor antibiotic. Anthracycline that we talked about, doxorubicin, idarubicin, mitoxantrone is also similar to anthracycline. Epirubicin, these are basically anti-tumor antibiotic which is used for a variety of malignancies. Somebody was asking this question, what is anti-tumor antibiotics? There's a question, how to calculate the carboplatin, doctor. Carboplatin, we use Calvert formula. I think Dr. Ines and SOPA administration will share with you our slides. So we use a formula called Calvert formula. In Calvert formula, we use AUC plus creatinine clearance plus GFR, and you have to multiply this with the AUC, and that's the called Calvert formula. There is another question, another to use anti-cancer. I cannot understand this question. Is there another equation for carboplatin calculation? Yeah, Calvert formula. Is also called anti-topoisomerase. I did not understand this question. So we have topoisomerase 1 inhibitor like irinotecan, and we have topoisomerase 2 inhibitors such as etoposide and anthracycline. Did drug interaction with cotrimoxazole and methotrexate? Yes, because cotrimoxazole has trimethoprim and methotrexate, they share the same mechanism of action, dihydrofolate reductase, and that's why they are not recommended to be combined together, and that increases the toxicity of methotrexate.
Doctor, there is a question from YouTube. What is the management of hemorrhagic cystitis if happened?
Yeah. So if hemorrhagic cystitis happens, so what we do basically, we continue mesna and we continue the IV fluids. And if it is really aggressive, then sometimes we use also the bladder irrigation with the mesna. Bladder irrigation with the mesna. Mesna is mercaptoethane sulfonate sodium. Okay.
There is another question from YouTube also. Mm-hmm. Is the toxicity of anthracycline in the heart reversible or irreversible, and we can overcome it? Sorry.
No, the cardiotoxicity of the anthracycline is irreversible. So what happens basically, there is different types of cardiotoxicity. If I talk about cardiotoxicity, it will take 4 or 5 hours for me to talk about the cardiotoxicity of anthracycline. There is early onset. There is acute toxicity, which is like arrhythmias. That could be reversible, that comes and goes, acute toxicity. There's early onset toxicities, which can happen within a year, and that is really cardiomyopathy, congestive heart failure, ventricular tachycardia, and these kind of toxicities are not reversible. And there is late onset, which can happen even 5-10 years. So these are not reversible. So if they develop congestive heart failure, you have to provide the heart failure therapy like you treat any other heart failure patient. Any other question? So somebody is asking how to use methotrexate for rheumatoid arthritis. For rheumatoid arthritis, we use smaller doses of methotrexate, like weekly basis. But for leukemia and lymphoma, we use higher doses. Dr. Ines, is there any other question?
There is a question. What is the effective of combination of leukemia treatment?
Okay, for leukemia, leukemia is basically two main types, acute leukemia and chronic leukemia. And acute leukemia is mainly two types, acute myeloid leukemia, acute lymphoid leukemia. And there is hundreds of types of AML and ALL actually. And so what we do basically, the combination therapy, we use intensive chemotherapy plus minus target therapy in order to achieve complete remission. The complete remission, which is defined as like the abnormal cells, blast cells should be less than 5% in the bone marrow. The normal blood cells should be normalized. For example, the CBC should be normalized. Like, for example, neutrophils should be more than 1,000, platelets should be more than 100,000. There should be no extramedullary disease, and like this. So with the induction chemotherapy, which is combination of at least 4 drugs or 4 plus more drugs, we achieve the complete remission. And in consolidation, we use also similar to the 3 to 4 drug combination in order to consolidate the remission state. And also in the maintenance, we use low dose chemotherapies in order to prevent the cancer coming back.
Okay, thank you, Dr. Mansour. Thanks a
Thank
lot
you.
for this very informative session. Thank you, Doctor.
Thank you so much. So Khalas, I can leave then, huh?
Yeah, thank you.
Thank you so much. Thank you so much. Good luck for the whole course. Thank you so much. Jazakallah khair.
Yeah,
Assalamu alaikum.
مع السلامة. شكرا. شكرا لكم جميعا. You can take a break بس لا تخرجوا من الزوم روم. ممكن تاخذوا بريك لين الساعة 9 هتبدأ دكتورة نورا إن شاء الله. بس keep yourself mute ولا تخرجوا من الروم. Thank you.
إيناس. هاي.
أيوة أهلا دكتورة.
كيف حالك؟
الحمد لله.
I will try to share my screen. I don't know if it's gonna be. I'm trying to do this like presenter mode. Let's see. Can you see it now, Inas?
Yes, clear.
طيب لا. Let's try to change the slides. I don't know if it's gonna be okay. Okay. ممتاز.
Clear.
طيب, let's see if I can open the chat on the side so I can see when people ask questions or answer the questions. Perfect. Okay. كيف الوضع الحين؟
Clear.
Awesome. Okay, perfect. ممكن نبدأ بعد شوي بس أول ما. Okay, let's keep this in the beginning. Okay, I will mute myself until it's time. Like in 4 minutes, we'll be back.
Okay.
Are we ready?
السلام عليكم دكتورة نورا.
هلا.
يلا نبدأ دكتورة. مرحبا يا دكتورة.
يلا. تمام.
So let's welcome our second speaker, Dr. Nora Alkhudair, Assistant Professor at King Saud University College of Pharmacy and the Hematology Oncology Clinical Pharmacist in King Saud University Hospital. She will present for us an overview of targeted and immune therapy. You can start now, Doctor. Good luck.
Shukran Abdurrahman. Thank you, Sopa, and thanks to Inas and Abdurrahman for making this great effort in order to make this course works. I know some of you guys are upset because of the Zoom capacity, and I know that they're going to work hard in resolving those problems, inshallah. So our presentation today, I'm trying to make it short. I know it's the end of the day, everyone is tired. Feel free to type in the chat as we go. I will keep seeing it on my screen as I go, and we will make it more interactive discussion. I wish I can unmute you guys and you can talk with me, but as you know, the number of learners are really high. So the objectives for today's lecture, we're going to talk about the side effects of novel agents. I will concentrate more on novel agents, the new therapies that have been lately approved in cancer. And we're going to review the management of those adverse events, monitoring parameters of selective agents. And we're going to discuss the interaction associated with novel agents. So first of all, we need to talk about the immunotherapy, the types of novel agents that we have. So novel therapies can come into either immunotherapy or targeted therapies. And immunotherapies are the ones that are stimulating the patient's own immune system in order to work harder and smarter to attack cancer cells or supply immune system components to fight cancer cells. However, targeted therapy will focus more in really focused mechanism of action and specifically act on biological pathway when inactivated and causes regression or destruction of the malignant process. So the next slide will show you and I will point it over here, the different sides of the targeted therapy and immunotherapy, where they work exactly. So the monoclonal antibodies work in the extracellular domain, which is the outer side of the cell. In the intracellular domain, we can see the small molecules, proteasome inhibitors, and mTOR inhibitors working over there. Sorry for that. Next slide is when we see the hallmarks of cancer and how cancer is developed, we can see that it compromises 6 biological capabilities acquiring during the multi-step development of the human cancer tumors. However, those hallmark of cancers recently been updated in 2011, and we can see additional pathways that have been added to the already coexisting hallmarks that we know. So we have more targets now and more smarter ways in tackling cancer cells, not only the cell cycle that Dr. Khan just talked about. So today I tried to minimize the amount of information when we look at novel agents, and that's what I usually teach pharmacy students at the college. And I think those are the most important ones to know about when you go to practice. Novel agents, we're going to talk first about complement-dependent cytotoxicity, CD2 inhibitors, monoclonal antibodies, and then we're going to talk about immunomodulation, including immunocheckpoint inhibitors will play a huge role in different types of cancer. So please bear with me because they are very, very important. Then we're going to talk about altering signal transduction, including HER2 in breast cancer, EGFR in various cancers, multi-kinase inhibitors, BCR-ABL in CML cancer patients, and targeting angiogenesis in VEGF inhibitors. So first of all, we're going to talk what's complement-dependent cytotoxicities. When we say CD, we mean cluster of differentiation, and it's a cell surface molecule that allow phenotyping and targeting cancer cells. So we usually, when we when we look at those cancer cells, we will see that they express those certain molecules, and we can easily target those in order to stop cancer from growing. The first one and the most famous one is rituximab that we're going to talk about. Rituximab used in different type of cancer and non-cancerous diseases. Usually it's a flat dose of 375 milligram. The most important thing in rituximab when it's used, so rituximab, as we said, binds to CD20 expressed on B lymphocytes, activating the antibody-dependent and complement-dependent cells cytotoxicity. Rituximab usually is given IV. Nowadays, we have some subcutaneous rituximab formulation, which is a combination of rituximab and hyaluronidase, and it's given sub-Q over 5 to 10 minutes, depending on the syringe size when you prepare it. Usually, when you give rituximab to patients as an IV, and usually it's the first dose before you switch to subcutaneous if you have it in your institution, you need to pay attention to, first of all, because we are a pharmacist, in the dilution. So you need to dilute it at least, I would say, perfectly 1-to-1, but not less than 250 milligrams of mLs of NS. And also the most important thing is the initial rate of administration. So no more than 50 milligrams per hour. Anyone knows what's going to happen if I infuse rituximab faster? Or so that in practice, if you guys are have been in a hospital setting? Shock? Any other? Anyone wants to participate? Infusion-related reactions. Why? Why does that happen with rituximab? Hypersensitivity. So what symptoms exactly happens? It's not extravasation. It's hypersensitivity, definitely. Anaphylaxis. Anaphylaxis is the inside of a hypersensitivity reaction, but I totally agree. Okay, so basically, I think I moved to the next slide. So basically what happens when, how do we need to infuse it? Basically, we infuse the rituximab in 50 milligrams per hour. And then if no reaction happens to those patients, we give it in more 50 milligrams increments every 30 minutes until we reach 400 milligrams per ml. So no more than that when we give it to a patient. In subsequent cycle, if you're still gonna give it IV, it's recommended to start with 100 if no reactions happened, and then you increase by 100 every 30 minutes later on, up to 400 milligram per hour. So that's only if patient tolerated the rituximab. Also, the other important thing that you should give patients before starting rituximab hydrocortisone, diphenhydramine 5-HT2 inhibitors, and so antihistamine H1 blockers, and you give some hydrocortisone and paracetamol to prevent those reactions. So as you all said, because of the source of rituximab, and we're going to talk more about this later. The symptoms of a reaction or infusion-related reactions that happens with rituximab include hypotension, angioedema, bronchospasm, hypoxia, urticaria. In severe cases, or if you keep infusing rituximab in those patients, acute respiratory distress symptoms can happen, myocardial infarction, anaphylactoid reactions, or death even can happen with those patients. So usually it started 30 minutes to 120 minutes with an infusion. So you give paracetamol, basically, or acetaminophen, Panadol before the dose. So 650 milligram or 1000 milligram PO before the dose, and diphenhydramine 50 milligrams oral or IV, there is no difference, before the dose. When the side effect happens, and this is very important for practitioners or for pharmacists in drug information when they are asked how to do it, how to deal with it, usually actually what happens if the infusion is not grade 3 or higher, we just hold the infusion, reapply pre-medication, hydrocortisone. If there is any bronchospasm, we apply some bronchodilutors, inhalers, and we give some glucocorticoids, and then we basically wait until those symptoms resolve. If they resolve, we reduce the infusion rate by 50% and we give it again to the patient. So we do not actually, it's not contraindicated unless a patient needed intubation and patient really had like really severe anaphylactoid reaction. So usually it's okay to re-challenge, it's okay to give it the patient, but after the patient go back to grade 1 and no side effects present on them, and then and pre-medicate them and then resume the therapy again. The other important aspect of rituximab use, before you verify the order for rituximab, as most of us are pharmacists over here, it's very important if you're sitting in inpatient or even outpatient kind of infusion clinic to make sure that this patient have HBV or hepatitis B test negative in their chart. Why I'm saying that? Because some cases of reactivation of HPV have been reported in patients with hepatitis surface antigen positive even. So what usually the recommendations are, and there is a whole guideline by ASCO, is you need to basically screen all the patients for hepatitis, because the abrupt increase in the hepatitis virus DNA level or detection of hepatitis B surface antigen in person who previously been hepatitis antigen negative, but the core is still positive in those patients. So what they recommended in the guideline is 2 arms. Basically, you screen all patients before you start chemotherapy, or specifically rituximab, even if they are not gonna receive chemotherapy. And if they are service and core positive, for sure you're gonna initiate therapy. If they are service antigen and core only positive, you need either to monitor or initiate therapy, depend on your local practice. The other important thing for you guys to remember is that you need to continue the prophylaxis during the treatment and up to 6 months to 12 months after completing the treatment. So that's it about rituximab. I don't know if you guys have any questions about it. Okay, perfect. So next we're going to talk about targeted therapy, and you can type your questions and we're going to go back to it. Do not hesitate to type your questions. Next and most important thing, we can talk about the targeted immunocheckpoint inhibitor. An immunocheckpoint inhibitor basically PD-1 inhibitor, PD-L1 inhibitor, and CTLA-4 inhibitors. And we can see them over here. So we have here the T cell side, and we have on the other side, or the purple cell, is the cancer cell. And basically what happens is those immunocheckpoint inhibitors work in inhibiting the tumor cell from binding to the T cell, either on the side of the tumor cell or the side of T cell, depending if it's in the ligand side, or in the inhibitory side, or in the ligand side, or in the other side. So for the ligand side, including durvalumab, atezolizumab, those are on the tumor side, and nivolumab and pembrolizumab, the most famous ones, are on the T cell side. Why we are doing this, or why we are targeting those cells? We are trying to activate the immune system. We are trying to activate the T cells in order for those T cells to go and kill the cancer, rather than being suppressed by the tumor cells, basically. So the most famous ones, or we started with ipilimumab, pembrolizumab, and nivolumab. Ipilimumab is the first one. It's a CTLA-4 inhibitor. It's used in treating melanoma patients, and nowadays we have more indications, including RCC and others, which is renal cell carcinoma. Sorry for the short terms that we always use in oncology. And pembrolizumab, Keytruda, and nivolumab came after and complemented the uses of ipilimumab, and also they have a wide variety. Like we just had MSI, microstability, high cancers as a first line, for example, in colorectal cancers were just approved. So usually when they are in the clinical trial phase, those agents are weighted, are dosed by the weight, and then after getting approved, they are usually given, I'm talking about Pembro and Nivolumab, the PD-1 inhibitor. They are given as a flat dose, as a flat dose usually in those patients, not per weight indication. So why they are important? They are used in various type of cancer, but we just have to remember that those agents activate the immune system, okay? So when you're activating the immune system, patients who have autoimmune diseases or patients who previously got solid organ transplant or patients who are on immunosuppressants for any reasons, you're actually counteracting that effect, right? You're actively activating the immune system, so you might cause complications for those patients. So it's very, very important that you need to screen all patients and make sure that they don't have any history of those indications. Also, they are not in steroids for any reason, because you're going to counteract the effect of the immuno checkpoint inhibitors. But the most importantly here is there are some data out there. So you need to talk with your physician and decide where you want to go with those patients. You might find some interesting case reports or so on, and you can decide as you go. But you need to acknowledge that. You need to tell your physician to talk with your patients and then decide, because those patients were excluded from clinical trials. So the other important thing as a pharmacist and as someone who's verifying orders, frontliner, when they call for a code, or when you see a patient in clinic with your team, sometimes you see patients with immuno-related adverse events. And basically, a lot of patients, for example, and you have those arrows looking at different organ systems that can cause those side effects. But basically, a lot of patients present with GI side effects, gastrointestinal, like diarrhea or colitis in severe cases. And this is a very common side effect, and it's not because of an infection or because of bacterial causes or any infectious causes that causes that diarrhea. Is basically because of the immune system being activated, and it's an immune reaction. So it should be treated in a different way that we're going to talk about in the next slide. Secondly, and the most one of the most common ones are the dermatitis, vitiligo, which is discoloration of the skin, and then also alopecia can happen in some cases. Hepatitis, so patients will have high levels of ACLT, and so on, so the liver functions will increase. Nephritis can happen, but it's more rare. Also, neurological side effects, cardiac myocarditis, this is very deadly, happens rarely, but it can happen, and also pneumonitis. So I had a patient, I remember, that presented with symptoms resembling pneumonia, and she was getting an antibiotic in the secondary hospital, not a tertiary primary hospital, and not knowing exactly that she got immune checkpoint inhibitor, she was mistreated by giving her antibiotics rather than giving her the proper treatment that we're going to talk about. And finally, some endocrine side effects like hypophytitis, hypo and or hyperthyroidism can happen, or adrenal insufficiency. So prior to starting therapy and during the therapy, you should basically check the patients for those side effects as you go. Here is the distribution of the side effects, but we can see that the CTLA-4 inhibitors have more common toxicities compared to PD-1 and then PD-L1 inhibitor. And then also combination therapy with PD-L1 and CTLA-4 causes more side effects because you're combining two different mechanisms in activating the T cells. Usually those side effects appear in 2 to 4 weeks of therapy, and it happens usually rash presented early. Not all the symptoms can happen in one patient, by the way. Some patients get certain side effects resolved, and then other side effects will come later, or they will have just single isolated side effect. So usually diarrhea, colitis will happen in the 4th to 6 weeks of therapy cumulatively. And then also in the same, I would say, range, liver toxicities and some of the endocrine side effects will happen. So basically, monitoring of those side effects, as I said, is very important. So when it comes to the endocrine, checking the TSH, adrenocorticotropic hormones, if with ipilimumab specifically, and the cortisol levels if the patients experience the symptoms of hypophytidis. But TSH, FT4 can be monitored as you go. Pulmonary, every 3 months they usually recommend it. And then also cough, shortness of breath for the pulmonary side effect. As I said, liver enzymes, renal function tests, and skin. You check the patient's skin, you educate them about it. It's very important. So when it comes to management, there is a whole guideline that is ASCO and NCCN combined together came out with. Here I just mentioned really short statements, but usually when patients have grade 2 reactions, when it's an endocrine reaction, you treat that. You give them thyroid for the hypothyroidism. But when non-endocrine therapy happens, and generally speaking, you have to basically hold, if it's a grade 2, for most of the adverse events, and consider resuming when the symptoms or lab values are back to grade 1. They can recommend here using a small dose of corticosteroids. In grade 3, you hold it and you initiate a higher dose of corticosteroid, and usually they recommend IV. In grade 4, side effects, and usually for those grades, for those you guys are not familiar with it or not explained for you in the school, there is the common terminology of cancer, and it's basically you go and you pull the PDF from the website, and you can get all the side effects and their grading from ranging from grade 1 to grade 4, and 5 is death basically. So 4 is the highest grade when it comes to those side effects, and it's detailed in the package insert. So basically when, and also the guidelines. So basically when grade 4 adverse events happen, it's very, very important that you discontinue therapy. And if it's endocrine side effects, it's okay that you re-challenge those patients. So next, important points really is just that you need to start steroids and taper it really slowly in those patients. So at least 4-6 weeks, so you don't want to reactivate again the same reaction. Another thing is 48 to 72 hours of high doses of corticosteroids in case of diarrhea or severe side effects happen, like in colitis and so on. You need to start some agents that can deactivate the reactions that happens, like infliximab, for example, for some of the toxicities, not all of them, but I'm just mentioning it over here so you can know that there is something else, not only steroids. Another thing is re-challenging. If grade 2 and 3 happens, is very important to check out the labs, and it needs to go back to grade 1 or less in order for you to re-challenge. Another important thing, dose adjustments or reducing the dose because of the side effects. It's not really recommended. It's not really recommended to be done. There is no value of that. So we're done with immunocheckpoint inhibitor. I hope you got all the important information. It's very important type of cancer agents and targeted agents that treat oncological diseases, and it's widely expanding in different types of tumors, either hematological and non-hematological. So feel free to type your questions. We're going to talk more about HER2 inhibitors over here. And HER2 inhibitors basically are human epidermal growth factor receptor inhibitors. And there are 3 different types that are used in breast cancer for those patients who express HER2. They are all monoclonal antibodies. We have trastuzumab, pertuzumab, adutrastuzumab, and trastuzumab, pertuzumab, and adutrastuzumab or Kadcyla. In those agents, they are basically used in, as I said, HER2 expressing females, and the dose and administration of breast cancer patients, and dose of administration of those agents vary on depending on the type of the agent. They are not the same, and they are used separately. They are not interchangeable for any reason. Their adverse events, and most importantly, as Dr. Khan just mentioned, that cancer patients receive AC, which is anthracycline and cyclophosphamide for treating of breast cancer. So they have some cardiotoxicity, anthracycline to them. And when we use those agents have also additional cardiotoxicity. So you never combine HER2 monoclonal antibodies with anthracycline therapy in cancer patients, breast cancer patients. So you should keep in mind that it's contraindicated to be given together if you're asking any exam, SPLA or even American board examinations. Another important thing that the mechanism basically of the immune reaction, the cardiotoxicity that happens is not really clear, but that HER2 receptors on cardiac tissue expressed in cardiac tissue, and it's a survival pathway for basically increasing the cellular transcription factor, production of nitric oxide, and also inhibition or reactivation of oxygen species. So basically, when you inhibit the HER2 cell survival pathways by using trastuzumab or similar agents, you can cause endothelial dysfunction, and congestive heart failure eventually can happen, or it can contribute into that later on. So you can see reduction in ejection fraction, and this is one of the main important things that you should check for when you see a prescription for trastuzumab or a chemo order that contains trastuzumab, pertuzumab, or Kadcyla. So this is a very busy slide. I know you really have to concentrate in 2 to 3 things here, but the most important thing that you need to check all your patients' left ventricular ejection fraction at baseline. You need to know that you need to hold the therapy for at least 4 weeks if anything happens, and there is a specific criteria for each one. And the third thing, you need to know or check the criteria for resuming therapy for those patients. So you need to know when to discontinue, definitely, and you can call your physician or meet them and discuss with them that this patient, no, we cannot resume it, basically because of that. For example, with the trastuzumab, the left ventricular ejection fraction is declined for more than 8 weeks and did not regain the function again, because as we said, it's a reversible side effect. Next, we're gonna talk about, and that's mainly it. You can see in the slide the different agents and the different way of managing it, but I'm trying to tell you about the most important thing that you should keep in mind when you basically use those agents. So if you have any question, feel free also to type. Next, we're gonna talk about EGFR inhibitors, and EGFR inhibitors basically I don't know if I included a picture of it here. Let me see quickly. No, there is no picture. So EGFR inhibitors are used in KRAS wild type metastatic colorectal cancers, and the most famous ones and approved ones in Saudi are cetuximab and panitumumab. And cetuximab and panitumumab and cetuximab specifically is approved in other indication. The most important thing before approving it, when you check the patient profile, you need to check the KRAS mutation, and it needs to be wild type, not mutant KRAS, because those patients will be resistant to EGFR inhibitor. Second thing, when you give those agents to the patient, you need to keep in mind that those agents, and you can see it over here, just like this cetuximab, just like the rituximab, it's a chimeric agent. So the immunogenicity is more on the high side comparing to other agents. So to keep in mind that those agents have higher immunogenicity. However, cetuximab have higher immunogenicity, specifically in eastern states in the United States. So in our population, we did not see that much of reactions because it's linked to certain type of mouse human antigen that is usually occurs or happens in because of exposure in those areas in the United States. So usually we don't really worry about cetuximab being infused and causing side effects in those patients, immune-related reaction. When it comes to panitumumab, and you can see it over there, it's less it causes less immunogenetic reactions, and it's similar monitoring parameters usually that we need to go over because of the general side effects of EGFR inhibitors that we're going to talk about. But usually with those agents, certain side effects can happen, and you can link the monitoring and side effects always as you go. Let me show you. I don't know why my slide is not moving. Okay. So number one, cetuximab hypersensitivity, and we talked about it, and we said it's not really common in our population. Those who practice in the United States and the southern sides, they should pay more attention. And this is the management of severe reaction, similar to rituximab, where you apply corticosteroids, you give bronchodilutors, you assess the vitals, you call codes if any respiratory therapy needed, and so on. But the most important toxicities that we should monitor and take care of in our population is the diarrhea and hypomagnesemia that can happen because of the EGFR inhibition. And the common way of basically preventing diarrhea in those patients, you can either prescribe loperamide and ask patients to take the dose when the diarrhea started, when they go home. And you should make sure that patients are not receiving metoclopramide or any prokinetic agents that can worsen the diarrhea or stool softeners, because as you know, patients can present with pain, and painkillers can cause constipation. And usually we prescribe for those patients stool softeners, but you should discontinue those agents in order to not worsen that side effect that can happen with EGFR inhibitors. Secondly, if it's a severe reaction, you could hold and reevaluate. And also you need to monitor fluids and electrolytes as you go. The second thing that can happen, the hypomagnesemia because of the diarrhea, and also EGFR works in the, there is some EGFR receptors in the distal convoluted tubules of the kidney. So basically it's a combined toxicity that happens because of two side mechanisms. And number one that you should do in those population of patients, you basically give them IV magnesium 4 milligrams IV weekly. And in severe cases, sometimes they need up to twice weekly infusions of magnesium. Also, you need to monitor the levels as you go and treat those patients. The small molecule EGFR, and when we see always small molecules, you should just pay attention to the suffix of the words. So you will always find that it ends up with INIP, INIP. So we have erlotinib, afatinib, ismertinib, and those agents are small molecules that are given orally, and not monoclonal antibodies that are given by IV routes. So those are agents that are given by mouth. Usually erlotinib, afatinib, and ismertinib are used for non-small cell lung cancer with EGFR positive. Nowadays, ismertinib, which is the third generation, moved to be the best or preferred option compared to afatinib and erlotinib. So just try to concentrate. Maybe you'll see more of ismertinib. If your institution is still having erlotinib and using it, just like a lot of institutions over here. Erlotinib is the first generation. It should be taken on empty stomach for those patients. LFTs and serum creatinine should be checked before starting therapy. And drug interactions, very, very important to be checked. So you cannot give PPIs, H2 blockers with those patients. And also smoking can interact with erlotinib. When it comes to ismertinib, which is the second common one, and it's moving up, it's already moved up in the guideline and it's used. So baseline QTC should be checked before starting therapy, and it can be given before or after food. The other thing is, if you have patients on inducers, CYP3A4 inducers, you should reduce the dose as you go. As a starting before you should reduce the dose when you start therapy. Management of selected side effects or toxicities, just like the IV ones, the monoclonal antibodies, diarrhea, stomatitis, other side effects that we're going to talk about can happen. But usually when your patients present with diarrhea, it's really dose limiting toxicity. So you can decrease the dose if that happens. The grade of side effects is different from one agent to another, but imatinib can cause up to 42% all-grade diarrhea. You can recommend or give your patient upfront loperamide to take it at home and to start to take it before at the onset of the diarrhea, and also electrolyte replacement. Hydration is very important, and BRAD diet. What we mean by BRAD diet is basically patients eating bread, eating bread and eating bananas and other. You can look it up, and it's recommended in those situations. Stomatitis, basically you manage it, or it's inflammation of the mouth, and you manage it by it's a dose-limiting toxicity, but you usually recommend patients to practice oral hygiene and also take analgesics and oncological mouthwash, which included numbing solutions to reduce the side effect and to improve the basically patient's willingness to eat and willingness to a quality of life. Another dermatological toxicities can happen, including rashes. Also, the soft tissue around the fingers or fingertips can also be affected, and usually they recommend warm soaks and creams to be applied to those patients. Also, some fissures on the skin can happen, and it's very painful side effect, and usually they recommend liquid Band-Aid or zinc oxide to be applied for those patients. The side effects, dermatological side effects, can happen as early as the first week of the treatment, and acneiform rash is a surrogate marker of activity. So you're basically, when you see it, you know that the drug is working, and you know that it's blocking EGFR, and that patient is benefiting from it. However, when it reaches a certain level of toxicity, or it's affecting the patient's life or causing infections, you should basically pull back and reduce, because it's dose-limiting toxicity. Here are the recommendations for the acneiform rash that can happen to those patients. You can either recommend topical or systemic antibiotics for those patients. Here is the finger side effect, and it happens because of the interruption of the retinoic acid metabolism and thinning of the stratum corneum around the finger, so infections and so on. I'm sorry for the picture. As I said, they usually recommend basically moisturizing the area, and if it's severe, you can use topical corticosteroids. Those are the fissures that can happen because of the same reason, and they recommend basically to moisturize and wear creams and use some Band-Aids for those patients. And here is the side effect, and usually patients who have eczema or older age, they basically, those side effects are more dominant on them. Here is the management, and emollients and exfoliants are recommended, as I said. So this is the end of the EGFR inhibitors. As we said, EGFR inhibitors can come as an monoclonal antibodies that given IV. Cetuximab and panitumumab are the most famous ones, used in head and neck cancers, cetuximab and other types, and also colorectal cancers. For panitumumab is colorectal cancers, and the oral ones, the most famous ones, is imatinib and erlotinib, which was one of the first agents, and it's given through oral route, and usually side effects of diarrhea, acneiform rash, and dermatological reactions are very common in those agents. So you should monitor, and make sure that you educate your patients before you start. We're going to talk next about multi-kinase inhibitors, and then we're going to go to BCR-ABL inhibitors, and we're going to end up with VEGF inhibitors. So feel free to interrupt and ask questions as you go. So the most common multi-kinase inhibitor, or as we call it, dirty kinase inhibitors, because they work on different levels of the protein, and they inhibit and they cause a lot of side effects because of that inhibition. Sorafenib and sunitinib, and those agents are used in, for example, sorafenib is used in advanced hepatocellular carcinoma and renal cell carcinoma, and sunitinib is used in just tumors and also renal cell carcinomas. Usually they are taken by mouth, and they are taken on empty stomach for sorafenib, and sunitinib we don't really care about it given with or without food. The other important thing for those agents is basically that there are side effects related to the tyrosine kinase inhibitor. So skin, hypertension, cardiac, and thyroid. So all the novel agents have somehow of cardiotoxicities that we need to pay attention to. And I have a whole separate presentation for that I presented in different occasions. But there is a really nice guidelines by American Heart Association, if you're interested about cardio-oncology, that you can read. And it tells you basically how to monitor and what's up there when it comes to treating and management of cardiac toxicity caused by chemotherapies, the old ones and the novel agents. The most important thing that when you start sunitinib, that you need to basically check for rashes, educate the patient about it. Hand-foot syndrome can happen, which is totally different than the acneiform rash or the rash caused by EGFR inhibitor. Monoclonal and the hypertension and the cardiac toxicity that is caused, usually the hypertension side of sunitinib is because of the VEGF inhibition, and I'm going to talk about the most famous VEGF inhibitor later. But usually you check the blood pressure at baseline and then weekly for 6 weeks on the starting of sunitinib, and you can evaluate if you need antihypertensive to be started or increased in case of your patient is already having hypertension. Another left ventricular dysfunction can happen, and it's not completely reversible, but usually you start with a baseline MOGA or echo scan before you start. Also, you need to monitor every 3 months the thyroid function, because those agents can cause hypothyroidism, and levothyroxine can be used in that case. Sunitinib also can cause hypercalcemia, hypophosphatemia, bleeding, and other different side effects because of the tyrosine kinase inhibition that can happen. Sorafenib is very, very well known for its diarrhea. If you see patients starting sorafenib, one of the main reasons for decreasing the dose or not tolerating it is diarrhea, because it can cause dehydration and eventually, if patients is not eating enough, no one's taking care of them, sometimes they can present with even AKI, so acute kidney injury. And the skin, hand, and foot infections syndrome can happen, which I'm going to give you some information about lately, and also hypertension similar to sorafenib. So here, the hand-foot syndrome is usually happens within the first 2 to 4 weeks of the treatment, and the incidence peaks really early in the therapy, but usually really plateau late on. This is why education your patient really about that side effect is very important to prevent stopping therapy and so on. So the mechanism of that, because of the VEGF inhibition and PDGF inhibition and disruption of normal process involving capillaries and fibroblasts, that can cause the hand-foot syndrome in those patients. So what is the presentation of hand-foot syndrome, or how we can diagnose those patients? So there are a variety of grades of hand-foot syndrome, but it will present with tender and scaling lesions, some arrhythmias around those lesions, and basically patients will have impaired range of motion and function, and weight bearing also. So you can see in those images that hand-foot syndrome can happen, and in hand and foot at the same time in those patients. So here is the hand-foot skin reaction that can happen with EGFR inhibitors and other agents, and it's usually greater foot involvement, and they are localized. And when it comes to hand-foot syndrome, it's usually symmetrical, some arrhythmias happen, and greater involvement of the hands can happen also. So they are both tender, they are both painful, but they are totally different. So how do you manage it? Usually you recommend patients, I remember them asking the patients to wear, to avoid wearing any constructive footwear and avoid excessive fraction. Also wear cotton gloves or thick socks to prevent any injuries that can happen to the foot. You can apply some lidocaine in case of grade 2 for pain control, and some ointments to prevent side effects. And if it reaches grade 3, you can recommend basically 7 days of stopping the therapy and then resuming if it goes back. Usually patients who take those agents, they give them skincare kits in the US and they go home with it in case any of those side effects happen, to prevent those side effects from happening. Next, we're going to talk about BCR-ABL, which I think really important medications that you can dispense in your patient in the outpatient setting, and you will see them commonly used for, and they are commonly used and only used for chronic myeloid leukemias. And those agents basically prevent the BCR-ABL gene, which is causes the chronic myeloid leukemia or Philadelphia chromosome from basically occurring and progressing to acute myeloid leukemia. So those inhibitors, including imatinib, dasatinib, nilotinib, bosantinib, ponatinib, are very common to be used. Those are the ones registered in the Saudi FDA. Imatinib, dasatinib, and nilotinib. They are different and similar at the same time. So they are tyrosine kinase inhibitor. They work on BCR-ABL. You can, if you're working in an outpatient pharmacy, you can see it easily dispensed to your patient if you are not separating oncology medication or a different pharmacist is processing them. For imatinib, you need to tell your patients that it needs to be taken with food. However, with nilotinib, it's an empty stomach. There's a really nice review over here that includes recommendations and comparing and contrasting about those agents. But here I try to make a lower or a smaller list of recommendations when using those agents. So you need to know that imatinib and nilotinib can cause hepatic dysfunction, and you need to reduce the dose in case it happens, or in case your patients present with some liver, baseline liver dysfunction. If patients present with renal dysfunction, imatinib need to be reduced, or the dose of imatinib need to be reduced. Drug interactions are very, very important. So NSAIDs and PPIs are really not recommended to be used with specifically dasatinib, and also tyrosine kinase inhibitors in general. But I think there is some data about using nilotinib with H2 blockers, but usually you need to check before giving your patients PPIs and H2 blockers, and inform your physician, because basically they need an acidic environment to be absorbed, those agents. They can cause neutropenias. Dasatinib is the most potent one when it causes more neutropenias than imatinib. However, imatinib patients usually get really severe GI side effects and distress, like nausea, vomiting, diarrhea. So when you're using imatinib, it's recommended to pay attention for those side effects. If it's really compromising the patient's quality of life, you might offer them to be switched to dasatinib if it's feasible in your institution or paid for. Fluid retention can happen with dasatinib. So remember, always patients who have heart failure, fluid retention gonna worsen their symptoms, and you should pay attention before starting dasatinib or deciding to start dasatinib, or even monitoring dasatinib in those patients. And finally, by waiting patients, like when you wait patients at least weekly in the beginning of therapy, you can monitor if they build up fluid or gained some fluid. Another thing with nilotinib is one of the agents that can cause a metabolic syndrome in patients who have cardiac side effects and have hypercholesteremia, hyperglycemia, like diabetic patients who have metabolic syndrome. Nilotinib is not really a good choice for them, because it can worsen that. It can increase the cholesterol, triglyceride, and also can cause hyperglycemia. So just pay extra attention when you start those agents. That's pretty much it. The other two agents are not approved by Saudi FDA, but some of the hospitals have them. To my knowledge, I might be wrong. Maybe they are approved now. But those agents we commonly start with imatinib, and my colleagues, I don't know if someone is going to talk about CML, but they will explain to you when they are used and why and how. So lastly, but not least, VEGF inhibitors, and VEGF inhibitors, they target the angiogenesis. So cancer cell is very smart. It can build its own blood vessels and blood supply. And by cutting that blood supply, we basically put those cancer cells to death. So that's the easiest way of describing angiogenesis and describing how VEGF inhibitors can kill cancer cells or induce cancer cell killing by a certain targeted mechanism. The most famous one is the bevacizumab, and the ramucirumab is used in metastatic colorectal cancer and gastric cancers mostly. And I'm not sure about Zaltrap if it's approved in Saudi. I need to double check that. But with bevacizumab and ramucirumab, those agents basically used by weight-based dosing for ramucirumab, and it's given every 2 to 3 weeks or in different ways. You can learn more about it in those specific lecture. But another important thing that those agents are not really, you don't need to give them with pre-medication because they don't cause any immune-related reactions. The main side effects, and one of the major things that you need to check for as a pharmacist and physician and every caregiver when you start those agents, that your patients with angiogenesis agents, including bevacizumab, patients who got recent surgery, it's really contraindicated because VEGF is really necessary for angiogenesis and the healing process of any cut or wound. So patients will have poor wound healing if you're giving them VEGF inhibitors at the same time or in an approximate time period of the surgery. So it's really contraindicated in major surgeries within 28 days. And then the other important thing, if you use VEGF inhibitors because it's interfere with nitric oxide synthesis, it can cause hypertension, and it's not dose related, and it's very variable, and there's no specific guidance on what's the cutoff of the hypertension that you should say no. But we usually know that any blood pressure above 160 over 100 is not really safe to be administered bevacizumab for those patients. So you should hold on, give some antihypertensives, and then resume or reuse it if patients are controlled. Another important thing is proteinuria that can happen because of the VEGF role in glomerular endothelial cells filtration. So having a checklist really, or a protocol that checks for all of those things in targeted agents is really important because it's becoming more complex for us pharmacists to check for those side effects. And then monitor, so basically baseline and every month the UPC ratio, the urine protein urine creatinine ratio, and you need to hold it if it's above 2 depending on your basically units that are used in your hospital. Another thing, bleeding, because of VEGF inhibiting the renewal capacity and activation of tissue factor pathways. So you need to monitor for bleeding, and it's contraindicated in any squam cell type lung cancer. And the other thing is, contrary to bleeding, is the thrombolytic events. And I saw it happening, and it happens sometimes in patients because of the release of tissue activating factor and activation of coagulation cascade that is happens because of VEGF inhibition. And usually you need to hold those patients. You need to at least stabilize patients on DVT or PE treatment for at least 2 weeks, and then restart when your patients are fully anticoagulated. And based on the therapy that you give, you can decide if they are fully anticoagulated or not, and you resume. But if patients are having life-threatening thromboembolism event, it's not really recommended to resume VEGF inhibitors. Hypersensitivity, never seen it. Never needed to give any pre-medication with those with Avastin slides. And I know it's been a long 45 minutes. Thank you for listening to me for the whole time. And I can see some of you are typing in the chat already. Please feel free to do that. The most important thing, as I'm reiterating and saying, as being a part of the clinical team, is that you need to basically grasp the challenges of oral agents. They are still interact with food. They still interact with drugs. They can, a lot of medication errors can happen. Patient adherence is another thing. When they come to take chemo, it's easy. You can see them, you can give them the chemo, you can monitor them, but when they take oral therapy, it's very hard. Also, if you're working in a private practice or if patients are not covered by insurance, coverage and cost is very important. And for us in hospitals, including formularies and deciding is another thing. Also, for you young fellows, you need to check for and monitor as you go those agents to be included or not included in your hospitals. Another thing, drug interactions, as I said, counseling patients, food and drug interaction, also patients on expected unique adverse events, and also you need to remind your patients about adherence. So the floor is open now for your questions, and I can see here maybe 2 questions. Let's see. Immune checkpoint inhibitors have different mechanism of action. Is there any tests or criteria to choose between them? So it depends on where are you using it and what setting. So when you learn about non-small cell lung cancer, I don't know who's going to present that lecture. I'm sorry, I don't remember the whole schedule. But you're going to know that PD-L1 expression is very important in using it first line or second line, and which agent to be used, or are you using it with combination of chemotherapy or alone as a second line in metastatic setting. So you don't use them haphazardly or interchangeably. You either use them specifically based on the guideline recommendation and the inhibition PD-L1 expression level. Some of them are indicated regardless of the expression, PD-L1 expression in certain settings, but usually there are certain recommendations by the guideline. And you're going to learn more as you go in this course. Let me see more questions. I hope I answered you. The anti-tumor antibiotics, also called topoisomerase, is an anti-tumor antibiotic also called. I did not, Abdulaziz, I'm sorry, I don't get this question. Anti-tumor antibiotics also cause. Topoisomerase inhibitors are, I don't know, it's a different, okay. Next question. Hand and foot syndrome, discrimination of hand and foot and palm are the same? No, they are not the same. No, they are not the same. We will share the slides. Okay, please could you send them an email? Okay, rituximab immunosuppressive. So why do you use it for cancer? Because they work on B cells, and expression of B cells can cause, misexpression of B cells can cause certain type of cancers. So you're targeting B cells in order to basically help in killing that type of cancer that's caused by B cell expression or misexpression. Great and important lecture. Thank you, Ahmed. So far, okay. They are asking from YouTube, when decrease the dose of selected EGFR drugs to manage diarrhea, does it affect the tumor treatment course? So basically, there are some data on sorafenib, I remember, in hepatic cancer, and you either have 2 choices. Either you do not administer therapy at all, and that's a bad thing because you're not giving any therapy, or you're going back to certain drugs that are not really working for those patients because you need targeted therapy, or you apply lower doses because patients are different and we don't know anything about different individualized pharmacogenomics in those patients. So I might express more than X or Y or Z. So they found out that actually reducing the dose and continuing therapy for a longer time is better than several interruptions or even not giving it at all. So basically, I would personally prefer to reduce the dose if the side effects goes down to grade 1, and then continue therapy. If patients are more fit and it's improved, I can re-challenge again, depend on the severity of that adverse event. And they have that recommendation usually in the package insert. Great question. Does erythromycin or other prokinetic agents are contraindicated in EGFR inhibitors? So it's just gonna cause more diarrhea, prokinetic agents, because they are moving the gut in those cases. But if you're treating something and you need to give them, you just need to pay attention and manage the diarrhea separately. If it's it's counterintuitive to give it together, but if you need to give it for a certain reason and diarrhea happens, you need to manage the diarrhea and to give basically a supportive therapy, electrolytes, hydration, and so on. Thank you so much. You're welcome. Thank you. Are there antidotes for those agents? Nope, not yet. Tariq Zahrani has a question regarding the hand-foot syndrome with VEGF inhibitors. Are the same with capecitabine? Similar, yes. شكرا لله يا دكتور، أهلا وسهلا. Does the blood vessels and capillaries needs to grow in normal situation? That's a good question. Yes, needs to grow in normal situation, but they are overgrowing in cancer cases. Are all the small molecular drugs end up with INIP usually? Yes, INIP, ismatinib, nilotinib, imatinib, and so on. Thank you, doctor. You're welcome. A patient have a HBV. We cannot give him rituximab. No, you need to treat hepatitis B. You know, you can give therapy to hepatitis B and control hepatitis B and then give rituximab. You cannot give it at the same time. إن شاء الله برسل لكم سلايدات بعد البرزنتيشن بعطيها Ines. I will send the slides. Don't worry. Any other questions from YouTube? Ines?
لا, I type all questions from YouTube.
Thank you guys. It was a pleasure. You can find me everywhere, YouTube. You can find me on Twitter. So if you have any questions, just let me know. Email me. Ines, I will provide my email in the slide. So feel free to do that. Thank you, guys.
Thank you. Thank you, Dr. Nora.
Thank you. Have a good night, everyone.
شكرا دكتورة نورا، يعطيك العافية، ما قصرتي. بالنسبة أول شيء يعطيكم العافية على الحضور، ونعتذر منكم عن التكنيكال ايشو اللي حصلت اليوم. الماكسيمم نمبر اوف سيت. إن شاء الله tomorrow all the registered students will be with us إن شاء الله. Tomorrow إن شاء الله we will have supportive cares in cancer patients. So it will be great topics, and see you tomorrow إن شاء الله. The first lecture will start at 8 and the last one will end at 10 p.m. inshallah. See you tomorrow inshallah.
Thank you all.